I'm Andrew Zolopa. I'm a professor of medicine at Stanford University. I'd like to thank you all for coming out tonight. It is appropriate that we're doing this lecture at the Redwood City Public Library, the former firehouse, because this is a hot topic. We're going to talk about sex tonight, and we're going to focus on what you need to know about maintaining a healthy sexual life. There are new tests available. There are new treatments available. There is new information about prevention of sexual transmitted diseases, and that includes diseases as serious as HIV and AIDS to bacterial infections like Chlamydia, Gonorrhea, and Syphilis. We're going to have two presentations that are kind of built together, and I'd like to introduce my co-presenter tonight to all of you, Dr. Annie Talbot, who is a clinical assistant professor at Stanford and a staff physician at the Sexual Health Clinic at Stanford. So, Dr. Talbot.
Thank you. Welcome, everybody. So you can detect already my French accent, so I'm sorry if I'm not clear. Please let me know, and I will articulate and talk slower. So welcome to this new topic for us. What is healthy sex in 2012? So we're going to try to define what it is and what we expect and what we'd like to discuss with you during the next hour or so. So healthy sex is practicing abstinence, monogamy, using condoms, getting tested for STI, having relations only with vegan people. Any other ideas? So what is the definition that we try to cover? So what we will talk about it tonight is definition, obviously. STI and their prevalence. We'll talk about Chlamydia, Gonorrhea, and Syphilis. And they are part of the bacterial infection family. We'll also talk about HIV and AIDS. That will be covered with Dr. Zolopa. We'll talk about how to prevent STI and getting tests, who, where, and how. So what is an STI? You know, I use that sounds or that word a couple of times. So STI stands for sexual transmitted infection. And we talk about sexuality related to having sex, personal intimate contact, rubbing of genital part, masturbating as partner, etc. Transmitted, it's passed by means of, spread of. An infection is being sick with or without symptoms. So STI refer to sexually transmitted infection. So an STI is an infection you can get from or give to someone else by having sex or by other intimate contact with him or her, applicable for both sex, obviously. So then, what is sex? So sex, by definition, refers to oral sex, mouth to genital contact. And we enter this category cunnilingus, oral stimulation of female genital part, or fellatio, oral stimulation of male genital part, or rimming, or ATM, stand for mouth to anus, or anus to mouth, oral anal contact. So vaginal sex, for which sometimes we're more used to, refer to insertion of the penis into the vagina. Anal sex, insertion of the penis into the anus, could be insertive or receptive. This is our important definition because that's what we refer to when we talk about sexual transmitted infection. So let's look at some statistics to see if it's important to talk about sexual transmitted infection of STI in 2012. So if we look at chlamydia, gonorrhea, and syphilis, you can see here data from the Public Department of California. You can see some statistics over 96 to 2011, and you can see the prevalence of the disease per 1,000 inhabitants. And you can see in blue the curve of chlamydia, in red the gonorrhea infection, and the green line on syphilis. You can see that chlamydia in 2011 is by far the most prevalent STI infection, following by gonorrhea, and then syphilis. And that's for men and women. If you look by gender for chlamydia itself, you see that chlamydia is prevalent in the female population more than in the male population. It is still California data. If you look at gonorrhea, the second cause of STI, male and female move kind of in the same way. In 2009, big decline, thinking that, oh, less and less gonorrhea infection, but see where we're going in 2011, increasing again. If you look at CDC, that's the federal agency looking at all infectious disease in the United States of America. They state that there are more than 19 million new STI every year in the United States of America. There are also estimated that 65 million people in the US live with a viral STI. More than half of the people will have an STI in their lifetime. By the age of 25, 1 in 2 sexually active persons will contract an STI. Half of the room here who have sexual activity will have an STI in their life. Less than half of the adult age between 18 to 44 have or ever been tested for an STI other than HIV. So we know that in the room, for people that have a sexual activity, half of it will have a history of STI. But we also know that less than half of us will have been tested. So that was some question that I heard, I thought it would be nice to cover. So I called it the truth or false. So I know that I don't have an STI because we wear each other's first, right? No. Can you get an STI from kissing? Yes, no, maybe actually. And it's not some clear-cut question. But the first answer will be maybe, depending on what's going on. Can you get an STI from toilet seat or hot tubs? No. I cannot have a second STI after I get treated. False. You can. I know everyone my girlfriend has been with, and they are clean. I don't need to be tested. False. It's not in the face of the people. You cannot know. If you have an STI, you got it from your current partner. Not necessarily. Some of the disease can stay in your blood for a long time before you know. I heard getting a checkup is expensive. Actually, not so much. And the quality of and the impact that you're going to have on your health will make the cost less expensive. Vaginal douching can prevent STI by keeping the vagina clean and healthy. No, it's not working. It's not a good way to prevent STI. And STI usually cause no symptom. False also. Most of the STI do not have any symptom. Come on in. Welcome. Come on. Hi. Hi. So let's talk about some STI at this moment. We know that the first most prevalent one is chlamydia. We saw that in the curve previously. So chlamydia is called often the silent epidemic. So we know that chlamydia is caused by a bacteria named Chlamydia trachomatis. It's part of the bacterial infection, and is spread person to person during a sexual activity, referring to the definition of sex that we had previously. The infection can include many parts of our body. Can be cervix, or in the vaginal part, the urethra, the upper genital tract, the anus. But the throat can also be infected depending on which type of sexuality you use. It's curable with antibiotics, for which is a good news, and it's preventable with latex condom, for also a good news. Just a picture to show you the woman reproductive system, just to show you that chlamydia can affect the cervix that we talk, or the intern part of the cavity called the uterus, and it can also go to your ovary or the fallopian tube. Chlamydia in a woman is usually no symptom. Most of the females feel fine. So we don't have any symptom. We don't know we have the disease. So we don't know we spread it. For the people that have some symptom, they could feel vaginal discharge, burning or pain when peeing, or lower abdominal pain. If we don't get treated and we keep this infection for a long time, some complications can occur. Painful pelvic inflammatory disease, trouble getting pregnant later in life, or dangerous tubal pregnancy, for which it's easier to get tests and treat earlier in the course of the disease than wait that the complications occur. The second most common STI in the United States is gonorrhea. It's also caused by a bacteria, and the name is Neisseria gonorrhea. It's spread also person to person during sexual activity. The infection can include many parts of the body, the same part in chlamydia: cervix, urethra, upper genital tract, anus, throat infection, possible if you have oral sex. It's also curable with antibiotics, and is preventable also with latex condom. Some pictures to see the male reproductive system that time, and you can see that the infection can be at the first part of the penis, that's called the urethra, and it can also be part of the epididymis, more in the testicular part. If you look at chlamydia and gonorrhea in men itself, men also can have no symptom. And if they have some symptom, it could be urethral discharge, burning when peeing, and testicular pain. The complication, if we don't get treated and we let the disease be there for a long time, you can have irritation to the urinary tract, infection of the tube and testicle inside the body, or trouble getting a woman pregnant later in their life if the infection stay there and not get treated. Just another picture to show if the rectum have the infection. Let's talk about the third infection called syphilis. It's another bacterial infection, and it's divided in 3 phases: primary, secondary, and tertiary. This is the data for primary, secondary, and syphilis rate by gender in California, again, for the same database, the Public Health Department of California, and you see that syphilis is more prevalent in the male population. So syphilis is also a bacteria, like I said, and is spread by sexual contact. Like I explained, primary, the first stage, is normally a painless sore anywhere sex can occur. Secondary is mostly a body rash. Many have no symptom. It can happen 1 month after the primary infection to few years after the primary infection. And tertiary, the third phase, can occur more than 20 to 30 years after the first contact with the bacteria, and most of the time have no symptom until neurologic symptoms occur. And we'll talk about that a little bit later. And it's also curable with antibiotics. A picture to show you the stage 1 or the phase 1 of the syphilis often occur like a scratch or something on the genital part that is not very painful and is not supposed to be there. So we have to think about it when we see it in ourselves or we see it in a context of medical care. And the bacteria involved is the Trypophana pallidum bacteria. So the infection continues in your blood until no treatment, even though symptoms go away. So you could have this sore, then it's going to go away by themselves. You maybe never have the rash, or maybe never notice you're going to have the phase 2 and the rash. And then year will pass, and the infection will be there, and you can have side effects after 20 or 30 years later. And we talk about heart problems, memory loss, stroke-like problems, infected baby, if it's the mother that's having it, or if she's pregnant and she delivers a baby and she has an active disease, you can have birth defects, mental retardation in the kids itself. All that without knowing it if you don't get tested. So I will pass on Dr. Zolopa to talk about another disease called HIV.
Thank you, Dr. Talbot. So we're going to move from some of the old-fashioned infectious diseases associated with sex, that's the chlamydia, gonorrhea, and syphilis, to another infection that is also sexually transmitted, and of course that's HIV infection. These are statistics also from the CDC that show you that the number of patients that we have seen in the U.S. with an AIDS diagnosis has peaked. The number of new cases peaked in the early 90s. This was around the time that deaths associated with AIDS had also peaked. In fact, at this time here in the middle 1990s, death related to AIDS was the leading cause of death for young adults between the ages of 25 and 44 for men and women. And then you can see almost as rapidly as it increased, it plummeted. And the reason why it plummeted is because of the advances that we had in treatment for HIV infection, which you're probably aware of, that now patients are living much longer as a result of those benefits for treatment. As a result of that, because people are not dying so quickly of AIDS and have better life expectancies with the treatment, you see actually in the U.S. the prevalence of number of people with AIDS living in the U.S. is increasing over time. So that now it's estimated to be about 500,000 people with an AIDS diagnosis. We know that if we include HIV-infected patients who have not had an AIDS diagnosis, the number of people in the U.S. is estimated to be about 1.1 to 1.2 million individuals. There are new infections occurring with HIV at about the rate of 70 to 75,000 new infections each year. We'll talk a little bit about that in a moment, but despite the advances we've made in the treatment of HIV, we haven't seen real improvements in preventing HIV, at least not as much as we would hope. So we're still seeing new infections, and new infection rate has been pretty constant over the last 15 or 20 years of the epidemic, unfortunately. So what are we talking about here? There's some definitions. HIV stands for human immune deficiency virus. It is spread by blood or body fluids during sex or sharing needles that are not clean. It also can occur that the mother who's infected, if not on treatment, can transmit that infection to her unborn child during pregnancy. About half of the time, people that are HIV infected do not have any symptoms at all. They don't know they've been infected. The other half of the time, there may be some symptoms, but they attribute it to a flu or a bad flu. And they get over those symptoms, and they don't know that they've become HIV infected. Now, despite the lack of symptoms, we know that the virus continues to grow and replicate in the body, and that can occur over years as it's destroying the immune system of the individual till the point where the immune system is so debilitated from the infection that they end up with an AIDS diagnosis. That process usually takes about 8 to 10 years. And patients who are infected with HIV, of course, can be transmitting it over those 8 to 10 plus years that they're infected. So if we look at the prevalence of undiagnosed HIV, I mentioned to you that about 1 million or 1.2 million people are infected. About a quarter of them don't know they're infected. So despite the fact that we've had tests for HIV for more than 25 years, the tests are readily available in most public health settings and clinics, many people who are infected simply don't know they're infected, and so they're out without knowing that they're infected and spreading it to other people. So you can see here by risk category as well as by gender the rate of undiagnosed HIV. MSM stands for men who have sex with men, or gay men. About a quarter of them are unaware that they're HIV infected. If you look at high-risk heterosexual individuals, men and women, men tend to be a little bit more likely not to know that they're infected than infected women, but again, 21 to 25%. Injection drug-using populations, actually a little bit lower in terms of not knowing that they're infected, probably because people who are injecting drugs are also having other health problems, getting into the health system, getting tested as a result of coming to emergency rooms or clinics. So there you see about 15% or so that are still unaware of their infection. Then you can see other categories as well. So overall, about 21 to 25% of people that are infected with HIV in this country don't know that they have the diagnosis. And that's important because it's actually that quarter of the population that's responsible for the bulk of the new infections. So as you can imagine, people that don't know they're infected may not be changing their sexual behaviors, and that's leading to other infections. So you can see here, 25% of people living with HIV unaware of their infection, but they're responsible for more than half of the new infections. It has been shown in a number of studies that when people test and find out they're HIV positive, that usually modifies their behaviors. So they may use condoms more frequently, they may be more selective about sexual partners, that type of thing, where if you're not aware of the infection, of course, you're going to be spreading more. So this is the idea of a core group. We know that for many sexually transmitted diseases that are occurring in a population, there's a group that are responsible for more of those infections, either because of their behaviors or their biology. In the case of HIV, we know, for example, that people that are newly infected, their viral loads are much higher. So that means that they're more infectious to those sexual partners or needle-sharing partners that they have compared to somebody who has a lower viral load. Okay. Now, the other thing about that's important for people to know is that there are now tools to prevent from becoming infected. There's big campaigns to get tested. We'll talk more about that in a moment. But we actually have now some tools in our tool belt to help prevent infections. And this comes under the category of PrEP. PrEP stands for pre-exposure prophylaxis. We have seen now in a number of studies this data from Africa in heterosexual couples, men and women, that if you give a pill, which is part of the treatment we use to treat HIV-infected populations, it's not a complete regimen, but it's part of a regimen. It's a once-a-day pill that you can actually prevent infections about 2/3 to 75% of the time compared to a placebo control. So these were placebo-controlled studies that were conducted in Africa in high-risk populations, and they showed that these medications can actually reduce the infection rate. We've seen this also in gay men and MSMs. That's been published in what was called the IPREX study. Again, the same design where they took high-risk, in this case, young gay men from Latin America and the US, and they randomized them to either getting the treatment, the tablet that's called Truvada, it's marketed as Truvada, once-a-day pill versus placebo. And again, in that study, they showed about a 45% protection effect. So in groups that are at high risk, giving them a pill a day can actually reduce their risk of becoming infected, which is important information for us to have. There's not a FDA approval for this yet, although actually that is being presented to the FDA next month. And that may change the label indication for this medication that currently is only label indication is for treating HIV infection. But now we're talking about preventing it. It was safe, it was well tolerated. Not everybody took the medication, though, and I should just make a mention here that in these studies, when they looked at the individuals in the study that actually had measurable drug levels, that they were taking the medication as prescribed, the protective effect was over 90%. So in fact, these pills are very effective, but like most things, if you don't take them, they don't work very well. In fact, some of you may be aware that there was a study in Africa in women. It was called FemPrep, and that was actually stopped early because it didn't work. It turns out that in that study, for whatever reasons, the women that were in that study didn't take the medication as it was prescribed. Most of them didn't take it. So there was there was no efficacy to the regimen. So if you take these pills, they actually are highly effective at preventing infection. This is one of the tools that we have available in terms of managing patients. In these studies, I should mention that everybody was counseled on safe sex. Everybody was provided with condoms, free condoms at every visit. Despite all of those efforts to try to prevent transmission, behavioral measures, these biological measures using a medication was effective on top of that. So these are powerful tools that are available to us. So a few questions here that I think Dr. Talbot and her team put together. I'll read through that. HIV, won't I feel sick? It's a serious infection. People die, of course, if you don't treat HIV. So the question is, of course, won't I feel sick? And actually, it turns out that for most of the course of the infection, for most individuals, they don't feel sick at all. Not until the very end, when they start having these opportunistic infections that we characterize as AIDS. I did mention that about half the time people will have a flu-like illness. If you ask really hard, that people, maybe more than half will actually say, oh yeah, actually I do remember a few months ago being really sick with the flu. I thought it was just the flu, but it turns out it was probably their HIV infection. And then as I mentioned, the virus continues to replicate, and as it replicates over time, it destroys the T cells. That's the measure of the immune system that we use. And when that happens, AIDS develop and people become quite sick. So the only way to know for sure if you're HIV positive is to get tested. And the tests are very reliable and they're very easy to do. Most of the tests that are available require a blood sample, but we do have rapid tests where a swab from the mouth can actually be done, and it's quite accurate as well. There's a whole long list of other sexually transmitted infections that we won't go into detail with you tonight, but if there's questions, we're certainly happy to address those. But they include herpes, of course. We don't have any cures for herpes. We don't have any pills like we do for HIV to prevent herpes, at least nothing that's been studied systematically. It is a viral infection. There are treatments for the infection to help keep it suppressed if one does end up with herpes. Probably overall the most common sexually transmitted infection in developed countries like the US. We know that HPV, it can be transmitted sexually. Of course, now we have a vaccine that's available for young women and boys and girls to prevent them from becoming infected later in life. Hepatitis viruses, hepatitis B has traditionally been a sexually transmitted form of hepatitis. Hepatitis C, which was used to be called non-A, non-B because we didn't have a test for it. It was controversial just a few years ago whether or not this was sexually transmitted. It is now clear that it is sexually transmitted. We're seeing that in our gay men in the clinic that we have patients where they're coming in with new hepatitis C infections, and that can also be transmitted heterosexually as well. And then there are other things like that are not as serious. Having lice, of course, is a sexually transmitted disease. Chancroid, another bacterial infection. LGV, which we see occasionally in the gay population, but it's generally seen in developing countries. And trichomonas, oftentimes in women. So maybe at this point, I think I'll turn it back over to Dr. Talbot, and then I think we can open it up to questions. Right?
So, like Dr. Zolopa pointed out, just mentioned that at this moment, regarding vaccination, HPV, we have a vaccine to prevent the STI, and also hepatitis B. That's it. Hopefully, herpes vaccine will come sometime, somewhere, but it's not existing at the moment. So that's the two STI that we could think about vaccination. And all of these diseases can have different symptoms between pain, blisters, bumps, sore, discharge, itching, or liver disease for the one that affect the liver. So who should be tested? Returning a little bit at the question at the beginning, well, I think anybody should be tested. That's kind of the idea behind the presentation. We cannot tell who's more at risk to another, knowing that half of the population having a sexual life will, in their life, have a STI. So it's not in their face or not necessarily based only on symptoms. So we should encourage people to get tests, including people that have oral, anal, or vaginal sex, even if they use condoms or not. Anybody who share needles or use injection drugs should also be tested. Anyone who's pregnant or plan to be pregnant, or male who wants to have a baby, because we saw that some of the disease affect the capacity to be pregnant or the capacity to have a baby if you're a male. So how often we should be tested? At the same time, we don't want to go in the other extreme and be worried all the time. Should I have been tested each month? Each time I have a sexual activity? Every 3 months, 6 months? Actually, we don't have a right answer. Only when symptoms arise, when condom breaks, yes, for sure. If you have a new partner, if you think to stop to use condom in terms of prevention, and you want both of the partner to be tested, is different situation that you should think about getting tested. And how we get tested in 2012. So I decided to put the mannequin piece, the symbol of one of the symbols of the Belgium people, is a statue in the middle of Brussels for your interest. Well, the good news is chlamydia and gonorrhea now in 2012 can be tested on urine tests and no longer only on Q-tips. Remember, for men and women for a long time, the only way to get tests for gonorrhea and chlamydia is to have a Q-tips insert either in your cervix, so for women a vaginal exam, or for men in their penis, for which it was kind of painful and not very easy to sell. Now you can do it on normal urine. So it makes the test easier and more accessible. The other way to get tests is through blood tests for syphilis and HIV. And a lot of other tests is more by clinical exam, where we can make the diagnosis based on the symptom and the examination itself. So testing is confidential. Teens here in California can be tested for STI confidentially. Parent permission is not needed, but we for sure encourage parents' discussion. Information is private. But the public health department will be notified if a test is positive. So it is important to know that the way we have data regarding gonorrhea and chlamydia in the California population, if a test turned positive, is going to be in the public health department. All that is confidential. And what I should do if I have a positive test, let's say my ex-partner called me and said, you know what, I had a chlamydia. What I should do if I receive a call like this? Well, I should get tested, and I should see a doctor or someone that can check on me. And we also recommend not to have sex during the acute period of infection. If someone calls you to say you have it, or you yourself say you have an infection. Normally for the minimum of 7 days, particularly if you talk about gonorrhea or chlamydia. And condoms should be used for gonorrhea and chlamydia, like I said, the first 7 days. When it's a virus, the counseling is more complicated regarding HIV, herpes, how we manage our sexual life. And I think at this point, it's important to sit down with a provider and discuss all about sexuality. What is we have now for prevention? Dr. Zolopa talked about some pills for HIV prevention. Condom for men or women are still part and very important of the prevention. Also vaccination. I pointed out to you 2 diseases that we can promote vaccination. So what we have to say now about STI in conclusion? Well, STIs is curable for most of the disease. Some of the diseases are not curable, but treatable. And just trying to treat ourselves by our own products or try to go online to find some treatment because I think I have something is not recommended. We should go see someone that is a doctor, a professional that can examine you and do a checkup on you and offer you the test that you need. And remember, we can have more than one infection at a time, and this infection can come back if it's not well treated. And it's not because you had one infection one time that you cannot have it again. So it's important to repeat your test. It's not because you did it 10 years ago that you're clean for the next 10 years. So just to remember, get tests, talk about vaccination, think about protection, and discuss about sexuality and sex life with your team care. And if you don't have a primary care doctor, if you feel shy to go where your mom, dad go, or your husband go, or your wife go, then you can point it out a different sexual health clinic in your area. Stanford had one. Some counties have also. But I think it's important and it's part of a regular base testing. So open for discussion if you want now. Thank you.
Okay, so the question is, if you're taking the pill to prevent HIV, how long does it last before it wears off? All of the studies that were done in MSMs and in heterosexuals, the studies were conducted for daily use, that they were supposed to take it every day. But we know that these medications, when you're taking them, they actually get into the body, they get into the cells, and they stay around for quite a long time. So in fact, there has been some modeling done with dosing at twice a week, 4 times a week, and daily. And it turns out that based on the data from that IPREC study that I mentioned, I didn't show you any data on that, but in the study from the MSMs, that if they were taking the pill every other day, their drug levels would predict that they would protect themselves about 99% of the time. Now, we don't have studies yet that are dosing it more infrequently than daily. Of course, the ideal would be that you'd have a pill that you could take the night before or weekends or whenever one was going to engage in sex. But we don't have that data at this point. I think if we do see a change in the label for this, it'll be to use the medication daily. But I think the important point here is that if people are at high risk for HIV, that, as Dr. Talbot said, you get into a clinic to get tested, to make sure that you're using all the other behavioral methods to try to prevent infection. And maybe a daily dose of Truvada would be part of a way of protecting yourself against HIV. So great question. So if you're taking the pill to prevent HIV, Dr. Talbot, does it prevent you from those other infections that you were talking about tonight?
No. So gonorrhea, chlamydia, syphilis, or all the others are not protected by this pill called Truvada once a day.
Including hepatitis. So even though it might protect you against the HIV virus, is not protecting you against herpes virus or hepatitis B or C. So there are plenty of good reasons to still practice safe sex, but we know not everyone can practice safe sex all the time. That's why we still see sexually transmitted diseases. So it's really part of a prevention package, but doesn't stand alone by itself. And by the way, if those medications are considered to be used, it does require some careful monitoring. People will have to be have blood tests on a regular basis to make sure that their kidneys and liver and other organs are not being affected by the medication. So like anything else in life, the medications do have potential side effects as well, so those have to be monitored. In general, though, in all the studies that this has been done in healthy, sexually active individuals, the medication has been safe. It's been well tolerated and been quite safe. So that's the good news. Right. So the question is, if somebody ends up having a sexual encounter that might be high risk, say they've been out drinking and they're not protecting themselves in the way they might normally do that, and they feel that they might have been at high risk. If they are exposed to HIV, how long does it take before the HIV test turns positive? Well, it turns out that the standard test that we use for HIV tests for antibodies, and those antibodies take time to develop, probably something like about 6 weeks. So in those situations where people are potentially exposed to HIV, we sometimes prescribe not pre-exposure prophylaxis, but post-exposure prophylaxis, or PEP. And that's been done in the setting where somebody, for example, has been raped, or somebody has had infection where they know the person that they were having sex with turned out to be HIV positive. So in that case, they're prescribed the same medication that we're talking about for PrEP, and they use it for a month after the exposure, and of course getting HIV tests during that time. So generally speaking, it takes about 6 weeks or so for the test to turn positive if you were exposed. But if you do have that situation, if you find yourself in that situation, again, it's important to get into a clinic and be screened for that.
And to complete, for the other STI, if you look at gonorrhea, chlamydia, the most frequent, it takes a week or so before your test that turn positive. So normally you have a week of window that you could have the disease. We do the test and we don't know. But 1 week after exposure, when we do the test, normally we find the disease. For herpes, it's more complicated, including HPV. Also, its virus is longer, and we don't have good tests to find the disease itself.
So the question is, if you're HIV positive, is it okay to have unprotected sex with another HIV positive individual? And what we call this is serosorting, where positives have sex with positives and negatives try to have sex with negatives. It doesn't always work, of course. And the problem, of course, is that you might still get infected with your sexual partner's virus. So even though you have an HIV virus, HIV comes in a lot of different varieties. Some are more dangerous than others. Some are more resistant to treatment than others. So there are cases in the literature of people who have been infected on treatment. Everything is going well, their virus is well suppressed, their T cells are fine, they're pretty healthy overall. They have a high-risk encounter with another HIV positive who has a more resistant form of the virus, and they become infected with that virus, and you see their the virus come back in their blood, and they end up getting sick. So even though you're positive and you're having sex with another person who's positive, there's still risk for transmission. Now, with that said, we also saw last summer a very important study where they treated people who were infected. These were heterosexual couples. One of the couples was infected, the other in the couple was negative. So a discordant couple is what we say. And in that study, they took patients and they randomized them to either treat the infected partner right away or wait until they reached a certain threshold to start treatment. And it turns out that if they treated the infected partner right away, they almost completely eliminated transmission to their uninfected partner. It was 96% effective. So this is the idea of treatment as prevention. So part of the reason why we're out here at the library here in Redwood City tonight and why we're talking about the sexual health program is that it's important for people to identify whether they're infected, because even if you're healthy, even if you feel normal and you're infected, you could be transmitting that to other people, and you may want to get treated not only to help yourself from getting sick, but from preventing your infection to other individuals, which would be important. That's right. So, even if serosorting is not perfect, and people's information is not always perfect, and people are not always perfectly straightforward or candid when it comes to these kind of things, and so that is also an issue. So we still recommend, because of the other sexually transmitted diseases that you're exposed to, because of the hepatitis epidemic, because of the syphilis epidemic that we're seeing, that safe sex behaviors, including use of condoms, is important. What do you think about that, Dr. Talbot? Should married couples get tested?
I think so. I think everybody should be tested. Like I said, if they have a sexual life, that's pretty much the criteria, or had a sexual life at some point and never been tested, we should get tested. It's true that trust is the cement of a couple, but at the same time, some disease can be there for a long time before the wedding and nobody knows, and the time passed and the disease can be transmitted. So everybody should be tested. The frequency, it's another topic. Like I said previously, each month, 3 months, 6 months, once a year, but it's something we have to think and be able to go to a clinic or your primary care that know what to do and talk about it. I think it's important. And yes, couple, married or not married, and steady relation or not, should be tested.
It's I think a lot of us would say, oh, that's not a problem for me. I'm married, I'm happily married, and I don't have to worry about these things. But in fact, you saw the statistics. There are millions and millions of these infections in our country at all socio-demographic strata. Everybody has exposure to this. And as Dr. Talbot said, some of these infections hide. So herpes is a classic example. And so you'll have a couple that have been together for many years, and all of a sudden the woman gets pregnant and she has lesions, and it turns out she ends up with a primary herpes infection that she got from her husband that they never knew about, that was transmitted. And so these kind of things are important. The screening frequency, I think, is dependent upon your situation. Having a healthcare provider that's knowledgeable about these infections can help guide you. Many people are getting into new relationships. I think it's important that we understand that these tests are part of health screening. Just like you get your blood pressure measured, just like we get cholesterol measured, these tests should be part of normal adult healthy screening. People are a little squeamish about it at times, but in general, it's much better for us to just get tested, make sure we don't have those problems, and then if we do get treated, the treatments are quite effective.
A lot of the treatment for gonorrhea or chlamydia, and what I was saying is antibiotics, is often one-shot deal. So you take 4 pills once and you're done. For some, it's 1 injection and you're done. Sometimes it's 3 injections and you're done. So the treatment itself is pretty much easy for most of the STI. HIV is another topic, but for gonorrhea, chlamydia, syphilis, it's easy to get treat. So I think, and the treatment is not expensive either. So it's something we should also think about. It's better to get tests before we have all the complication, where the treatment will be more expensive and more complicated.
In fact, actually, probably the number one reason for infertility in young women trying to have a family is that they had a previously undiagnosed sexually transmitted disease that's led to scarring and fibrosis and difficulties with the anatomy to allow for pregnancy. So it is important to be proactive in this regard. So the sexual health clinic at Stanford, is it a specialty clinic? You need a special referral?
No, you can call, and you can also walk in and take a chance. We do not recommend it, just we want to make sure someone is there to welcome. But the front desk, either Kim or Halandra, will be there to orient you either by phone or in person, and you don't need a reference for that. And we also have different, I don't like to say that, but kind of package to include the visit to the doctor, having your test done, and having your results. So the price point was work with our manager and Justin and all the team at Stanford to make it accessible for the population.
So we want to make it easy for people, discreet, confidential, of course, professional, and get people to get tested. There is a push. We've done a lot of HIV care over the years, and there's a big push in this country to get people tested for HIV. We know certain groups are at high risk. African Americans have much higher risk of HIV infection, are not getting tested, not getting in treatment soon enough. We know that about 40% of all patients who are diagnosed with HIV are diagnosed late, which means within a year of that AIDS diagnosis. So they've been infected for 8 to 10 years before they know that they're HIV positive. By that point, although the medications are effective, they're not nearly as effective as if we had diagnosed them earlier and got them on treatment before they had the deterioration in their immune system. So this is a big push to try to improve an area of public health where we have very effective treatments, very effective simple tests that can be done to perform, and also effective prevention measures as well. So the question is about for treatment, for testing. Yes, the answer is most insurers pay for these. Of course, people can also get it paid, can pay cash. They don't have to use their insurance, but these are treatable conditions that are covered by most major health coverage. So why do we see more gonorrhea and syphilis in men versus women?
So that was part of a discussion I had today with Dr. Grant in the clinic. Why? We don't have a good answer. It's true that gonorrhea and syphilis are more, it's, the transmission, you have to spread person to person. So if you have more in a group of population, you have the tendency to spread in that group more because it stay in that group. So syphilis is one of the reasons. And the way you contract the disease also, one of the theories that is more and more in the air is that we find out that fellatio also transmitted syphilis in a higher rate. So that's kind of one reason we think that syphilis, because it was more in the male population, and through also fellatio, re-increase. We know also that syphilis and HIV is going together, and if you have both, syphilis make you more at risk to have HIV infection and spread together. It's also another reason. Gonorrhea versus chlamydia is not clear in terms of bacteriology or infection-wise why, but part of it is gonorrhea was kind of reintroduced in the gay population, so it's kind of transmitted, spread person to person more in this population, but it's a bacterial infection. Maybe Dr. Z, you can...
Well, I think in the Bay Area, the other obvious thing is that a lot of these sexually transmitted diseases are more prevalent in the gay population than in the heterosexual population. So you're going to see higher numbers of men with HIV, higher numbers of men with syphilis. And the syphilis epidemic that in San Francisco that they've seen, for example, is primarily, not exclusively, but primarily driven by the MSM population. So that, part of it has to do with the behaviors within that risk group. Right. So the question is, just to rephrase it, is the changing epidemiology of HIV from the time that the epidemic was first described in the early 1980s until now. It is true that initially in this country it was identified in gay men, but we know globally it's much, much more of a heterosexual disease than it is any other kind of disease. It's a heterosexual disease in places like Africa and Asia and other countries. So the vast majority of people that are infected with this, there's some 37 million people worldwide. The vast majority are heterosexuals that are transmitting it sexually. Injection drug users, particularly on the East Coast, were a hot spot in the 80s, early and mid-80s. But with the advent of clean needle and needle exchange programs, that really has dropped off quite a lot. In the West Coast, it was really never much more than about 10% of the HIV population that was injection drug use. And we don't really understand why that was. It was much heavier in places like New York and on the East Coast than it ever was on the West Coast. But in all areas now, because of needle exchange, because of clean needle programs, that risk has reduced. That's part of the harm reduction program. So in a way, it was kind of a fluke that it started off as identified as a gay disease, because in really fact it isn't. It's a sexually transmitted disease that, as we've been talking about tonight, affects all sexually active individuals across the globe.
So it's a little bit back on the same point at why gonorrhea is more in gay population. I think it's when you start to have an epidemic of a disease that is spread person to person, it's going to grow more in your population base where begin the infection. It's a little bit like cold in kids. When you go to kindergarten, you have the feeling that all the parents of these kids have cold too. Well, part of it is because kids are giving to each other that give to these type of adults. So it's a little bit the same idea. So here, HIV, correct me, you're involved at that time, but HIV was more entering in San Francisco through the gay population. So it gave a setting where it's still spreading more there, compared to Africa, where it was more between heterosexual people, where in Eastern Europe, like in Russia, they're facing more at the moment with needles and needle sharing, because that were where the epidemic was hit. So,
it's interesting. It's if you look at the history, it's now pretty clear that HIV started in human populations around the turn of the last century, so 1910, 1920s. It occurred in Africa, in the depths of Western Africa, and of course those people were so remote from any health care provision, and there was early mortality in those countries like the Congo and stuff, anyhow, that they were simply unrecognized. And it wasn't until the 1980s when we had enough travel and exposure that there was, gay men in Los Angeles, where the first report was, followed quickly by reports in other major cities, that we found out that it was a new disease. But in fact, actually, it had been in human populations for a couple of generations before that. We just never knew. Yeah, so this is the idea of what we call in infectious diseases a founder effect. And it just happened to come into a gay population first here. Yeah, so that's an important point. That may be a good point to end on. So the point is, the purpose for us to be here, the reason why we're taping this, and hopefully people will watch it at home, is to be educated. Education actually is the most powerful tool at preventing these infections. So, well, thank you all for coming out tonight to be educated, and thank you for the questions as well.
Thank you.